And thank you for joining us. My name is Jamie Butler, and on behalf of Hamamatsu, I want to welcome everyone to the session, and also on behalf of our new partnership and friends at BioCare, welcome. Thank you for coming. We're honored to have Dr. Bifulco with us today, a leader in digital and molecular pathology, and one of the driving forces behind the advancement of multiplex imaging and translational immuno-oncology. Dr. Bifulco has been instrumental in shaping how multiplexed immunofluorescence and advanced imaging can help improve immune profiling, biomarker development, and ultimately patient care. It's a privilege to have him share his recent study on non-small cell lung cancer. After Dr. Bifulco's presentation, we'll also have a short showcase featuring our collaborators, Spatomics, highlighting some of the exciting early joint work across chemistry, staining, and imaging, and establishing translational pathology workflows. A quick housekeeping note, though. We kindly ask that you hold the questions till the end of Dr. Bifulco's talk, and then again at the end of the Spatomics discussion for questions. But with that, please join me in welcoming Dr. Carlo Bifulco. Thank you.
Thank you, James, for the kind introduction, and thank you all for attending today. So these are my disclosure. I think the only relevant here is really that we are participant in the multiplex early access program with Hamamatsu. So the goal of the discussion today for me is to show a little bit how we think about spatial pathology and multiplex IF in a clinical kind of setting. And I will try to share with you possibly a pathway for the adoption of this kind of technology in the clinical space, in the diagnostic routine kind of space, and we'll go back also to the broader picture, hopefully. What you're seeing here is a slide coming from the current reality of precision medicine. There are clearly challenges, as you can see, despite the incredible advances from a genomics perspective and from a therapeutic perspective. So the reality is that many patients are not properly tested. This is a well-known phenomenon where many patients have single gene kind of testing. Many of them will not have sufficient material for having a complete kind of panel. And that translates, unfortunately, in delays in treatment and often in suboptimal kind of therapies. That's super evident in a domain like non-small cell lung cancer, where we have made so much progress from a therapeutic perspective. There are many reasons for this. I will focus on one of them, which has to do with the fact that very often the tissue is insufficient for having a proper diagnostic workflow. And, this actually translates in some kind of very impactful things. So it's well known at this point that if you treat patients with a precision medicine that may be either immunotherapy or targeted therapies to a driver mutation, the outcomes are much better. I think probably you all know patients who are now alive for 3-5 years who had a non-small cell lung cancer, which in the past would have died very rapidly. And if you compare it to chemotherapy, there's a huge difference. From economical burden, it's difficult to really assess that. I mean, there's an impact on lives, which is very clear. But the economy is more challenging because it's a complicated system, and I think it depends on the point of view, right? If you're looking at this from an insurance perspective, this may actually be not necessarily a negative. It reduces their cost. But actually, I think if you look at that from a pharma perspective and from a therapeutic perspective, it's a huge missed opportunity. So a lot of patients will never get a therapy that could have helped them. And also, it is impactful from a financial point of view. Why is that? And I think I'm trying to illustrate it here. So non-small cell lung cancer is very often advanced. Most of the patients already have locoregional disease or metastatic disease. All of those are not treatable with a resection, unfortunately. Surgery is not enough, which means that when you try to approach this diagnostically, you will approach it either with an FNA or transthoracic biopsy or a transbronchial kind of biopsy. And those are small. And what I'm showing you there, I think, is a slide. And you can see the little amount of tissue that is present there. And that little amount of tissue needs to give you a lot of information. We talked about precision medicine. And that is really driven by genomic findings, driver mutations, and you need to have a very large panel to identify those. And that will take at least 10 unstained slides, typically, that get put in the tube, and you extract DNA, and you run your molecular test. But also, you want to be sure that what you put in the tube is exactly what matches the pathology of the patient, right? So you will have an H&E at the beginning and an H&E at the end of that stack of 10 slides, and that makes 12. Also, you need to approach this from a diagnostic perspective, which means that you actually have multiple markers which are used for differentiating between adenocarcinoma and squamous cell carcinoma. The two groups have different kind of properties, and they need to be approached differently from a diagnostic perspective. And typically, in most of the labs, people run 4 stains, NAPSING-A, TTF1, CK5-6, and P40. Those are the most commonly used stains from a diagnostic perspective. And typically, 2 of those are positive in one differential diagnosis and 2 in the other. And then you have now therapeutic biomarkers for FDA approvals. And so HER2 is now approved for second line. The same is true for MET. And obviously, you all know about PD-L1 in this setting as a therapeutic target. I also want to mention TROP2, which is another ADC that is now available. And so actually, you have one additional on the list. So you can see that you have to get 20 slides out of the block, if not more. And that will only increase in the future. So there's a big push in trying to approach this strategically and in minimizing the waste of tissue. The other thing I want to mention is that what I'm showing you here is the ideal management of the tissue. So the ideal management of the tissue is that you do everything up front in one cut, and you get all those unstained slides, and then you process them in the pathology department. But if you actually approach that sequentially, you end up reeffacing the block and almost certainly lose all the diagnostic material. So this is the best case scenario, it's not the worst case scenario. And this is by recognizing guidelines. So the multiple guidelines, actually, you're supposed to be able to give results in 10 days, comprehensive results in 10 days to the patient. They are part of official NCCN guidelines and also pathology, molecular pathology guidance as well. And you can see that explicitly mention the fact that you need to use immunohistochemistry in a judicious way because of the importance of the molecular findings. So it's a recognized problem, and unfortunately, an unsolved problem so far. What have people done until now to try to approach that? Well, there's been some kind of approaches which try to multiplex brown stains. You can see examples here where people have been trying to do the 4 stains that I mentioned before, combining into pairs, and you can do that because one stain is nuclear, the other one is cytoplasmic. But obviously, you will appreciate that the results are not that great, and the level of multiplexing is not very high. People have tried to do this also in the literature, I think, in the past, on FNA material. Similar story. The colors are a little bit nicer, but you can see that, things are not nicely rendered as we would like it to be, and the level of complexity and multiplexing is still not high enough as we would like it to be. So can spatial biology help? Well, we hope so. I'm showing you here 2 examples of the incredible progress that the field has made recently. You have a paper, Nature Methods on the Method of the Year for transcriptomics in 2020, and a recent paper in 2024 about proteomics. So huge advances here. I think Aruta is in the room, and he presented recently on the ability to do whole transcriptomes or the ability to do thousands of proteins at the same time in a tissue. So things are moving incredibly rapidly in the research kind of setting, but they're not moving as rapidly in the clinical setting and in the context of clinical applications. And that's quite frustrating because if you look back at the literature, actually, people have been working on this for more than 20 years. I worked when I was at Yale with David Rim, and he has been saying for many years that the conventional approaches that we have currently for quantifying proteins in the surface of the cells are not adequate. They are imprecise, they do much better than fluorescence, and we should try to do better. At the same time, we also know that multiplex IF is a tool that is very powerful. And actually, it's funny because I'm now in the room. I don't know why we cannot show. Can I show this? Okay. We are now in a room here at SITC, and this is a paper which was presented for the first time in 2000, I think 15, if I remember correctly. I think it was published in 2017. It was presented here, won an award here at SITC. Bernie Fox, and and my friend Peng Sang. And you can see that for the first time, we were able to demonstrate that actually the microenvironment, the tumor microenvironment assessed by multiplex IF can help predict outcomes in head and neck squamous cell carcinoma. So it was the very first demonstration that this can work and have a clinical impact. And despite that, we're almost now 10 years or 9 years out, not much has changed clinically. The findings that Bernie had shown at the time have been replicated across multiple cohorts. I'm showing you here meta-analysis by Johnny Staub around the assessment of PD-L1 expression, demonstrating that actually multiplex IF does better in predicting outcomes than other modalities like single cell, single PD-L1, or even transcriptomics with signatures and other kind of solution and TMB as well. So huge body of work, rapid advances in technology, but yet no delivery. And I think the next slide will show you where we are currently. I think there are only 2 assays that have been run out or deployed in a CLIA kind of setting, in a clinical kind of setting. One is by Scott Rodick, the other one is by Joe Young. And I think Joe gave up. I think he had a multiplex IF for, 4 different monoclonal antibodies for PD-L1. And I don't think it's running that anymore because I think the field moved into more harmonization kind of approach. The other person you see there is Scott Rodick, which has been running a panel at Brigham and Women, I believe, for many years now. I think he has more than 1,000 patients with his multiplex IF panel on an Akoya platform, which is basically a predictive panel of outcomes. They are combining PD-L1, and CD3, CD8, and a few other markers in the kind of setting. They're able to stratify patients from a predictive point of view in ways that are quite interesting. I think the paper is not published yet, but you can find it in bioarchives. But it's not predictive, and it's been funded currently purely by philanthropy. So they don't have a coding or billing a code for this, and they don't have a great way to actually go and expand this for clinical delivery, unfortunately. So I showed you a little bit of where we are trying to go. We are trying to help and more efficiently utilize the tissue in a diagnostic setting, and we're trying to bring multiplex IF in the clinic in that specific context. And I show you now in the next slides a little bit how that looks like. So you have here the conventional administered chemical stains, and you have what we've been doing on this platform, the versions of the same antibody in a multiplex IF setting. We kept this as simple as possible. There are only 4 biomarkers, the 4 pairs I was mentioning before from a diagnostic point of view, because the intent was actually to simplify our execution from the clinical delivery. So there's no need for a mixing. Things go directly from the platform into your image analysis software, and they're very clean and simple at this stage. Of course, we could do more, and we'll talk about that a little bit later. So I showed you P40 and CK5 and 6. I will show you now TTF1 and APSIN-A. Again, you can see that the correspondence between the markers and just to put some setting, that TTF1 and APSIN-A are markers from adenocarcinoma, and the previous markers are markers from squamous cell carcinoma. A word about the platform. I think the Hamamatsu team is here. I think you're going to see more about this later. They also have a booth, but I think the intent of the platform is to actually clinical adoption. They're building things in a way that is as robust as possible from a workflow perspective, and is able to scale as much as it can scale. And also a word about the staining technology that we're going to use. So we did this with UltraView. I think those are antibodies which are barcoded. You can run them in parallel, which minimizes the complexity of your workflows as well. And a cool thing that they don't have steric kind of inhibition. They don't have tyrosine amplification, and so there's no big problem of overlapping signal and impediment of antibody binding and interesting sites. Another thing I want to mention, which I felt personally is very important, is that we made a big effort in making sure that we would retain the alignment of the underlying H&E with the images of the multiplex IF. I'm a pathologist. I like to see images in the context. And I can tell you that my colleagues in pathology also like to see image in the context. And the context they're trained to interpret pathology is H&Es. And so if you leave them with DAPI stains, they will tell you, I don't like this, almost for sure. So we made a big effort to try to make sure about this. You can see in this particular case that we actually do our staining, and then we destain the slide from the ultraview markers and do H&E and then align the whole stack. And we create a single file which has everything together in one shot. For validation purposes, actually, we also added adjacent IF, conventional immunohistochemistry. So we actually end up having a stack of more than 10 slides in one single OMT file. And I will show you a little bit how this looks like. And so you have here an adenocarcinoma. I think you can recognize the normal lung tissue on your left on the H&E, and you can recognize the tumor on the right of the H&E. And you can see how clearly the diagnosis of adenocarcinoma becomes obvious when you look at the staining. The green markers are all the adenocarcinoma markers, TTF1 and APSIN-A, one in green and one in yellow. And you can see there's absolutely no signal on the keratin side. And let me show you the opposite. Squamous cell carcinoma. Now you have the opposite pattern. Obviously, the signal is all on the keratins of CK5 and P40. And then you have the normal tissue, which is still stained by TTF1 and APSIN-A. So you see that, and you have the DAPI on the tumor. But you think you can differentiate those very rapidly. Now think about what the pathology does. They have to go from one brown stain to another brown stain. They have to memorize what they're looking at. They have to recombine this whole stack in their mental kind of framework. It works. They're trained to do this. They do it all the time. But look at how efficient and how easy this is. You just glance at the picture and you have the answer to your differential diagnosis. And you just click on a couple of buttons and you go from the H&E to all the biomarkers that you want to do. So we had proof of concept. We saw this was working, but we decided to design a little study around this. And we did this by pulling out 26 cases, I believe, of non-small cell lung cancer out of a cohort of cases which were actually evaluated from a molecular lab. My day job is to run a precision medicine operation, and so we have large cohorts of genomically tested lung cancer cases. And so we pulled those out from that cohort. Then we applied the panel, and we compared the results of the panel to the standard diagnostic workflow coming from pathology in terms of diagnostic classification, but also then you will see we'll try to do also some quantification work. I think I talked about most of the stuff before. We do registration of the H&Es and so forth. So what are the results? The results are basically very high concordance in this cohort. I think we had to pull out 3 cases. I think 2 cases were non-primaries of the lung. 1 case was, from a diagnostic point of view, insufficient. But pretty much every other case could be evaluated in this cohort. There was 1 case where we had a potential discrepancy, which is flagged here, the adenosquamous carcinoma. That's at 0 out of 1 concordance in the table. But as I will show you a little bit later, that case actually ends up being properly classified by the multiplex IF, and there was a mistake, unfortunately, in the pathology workup of the patient. I actually will dwell a little bit on that case in a second, but I just want to tell you that even if you consider this, you can see very high concordance, obviously, and almost perfect as it is. This is the adenosquamous carcinoma. Very advanced tumor in this particular case. You can see the tumor actually spreading to the pleura, invading the pleura, which is adjacent. This clear squamous cell carcinoma component. But when you run this under the multiplex IF, you see this. You probably remember the patterns that you saw before, the green and the yellow marking adenocarcinoma, and you remember the more bluish kind of colors on the squamous cell carcinoma. You can clearly see the 2 components here. I think it's pretty unquestionable and very easy to interpret once you look at this from this point of view. There are a couple additional things about this case. I'm showing you an enlargement of this from an image perspective to convince the people that are pathologists in the room that actually the 2 components are both malignant. And I just give you a zoom actually on the staining at the higher power to show again that they're very different in origin. What I wanted to mention here is that I don't think you can read it very well. The repetition I'm offering you is actually supported by molecular findings. So the case actually, I told you that we have genomic findings on all these cases. We actually had a fusion in MET, which is actionable, which is a great thing for the patient actually. But it's a fusion which is very rare in squamous cell carcinoma, which is seen at a relatively high frequency, I think around 5-6% in adenosquamous cell carcinoma, confirming the interpretation of the case that I just offered you, which I think is also very pretty clear from the images that you have seen so far. What else can we do? So I hope I convinced you that from a diagnostic point of view, this works and can be very efficient. But what about the quantification? What is the correlation between conventional immunohistochemistry and what we're showing you here in multiplex IF. So we've been doing work with Visiopharm, and you can see in this slide that we are using, again, the H&E as the source of truth in terms of segmentation of the tumor itself. So we can make the contour of the tumor out of the H&E. We can specify what is tumor, what is trauma from the H&E, and then we can dive into the components which are related to the quantification and segmentation of the nuclei and of the cells themselves. So that's the approach that was taken here, and I will show in the next slide some examples. This is the segmentation of the adenocarcinoma component. And as you can imagine, we can then quantify the nuclei. You can see on one side the original immunohistochemical stain, and then the rendering in the digital platform of identified cells and segmented cells. And I can show another example for P40, where again, I think you can have a very accurate and precise segmentation of both the tumor component and of the nuclei in the cell. So how do results look like coming out from this kind of workup? Pretty good. You can see here heat maps of the quantification of the conventional immunohistochemistry, so those would be the brown stains, versus what we are getting from the multiplex IF. And I think if you just glance at the heat map, you see pretty high concordance in intensity of the colors and patterns of those. There is one case which is standing out. I think you can see, cool. This one in red here, and the reason why it stands out actually is because the lab in immunohistochemistry used the wrong antibody. They used the cytokeratin Oscar, which is a pan-cytokeratin. It's staining everything in the lung from a epithelial perspective. It's not selectively for the CK5 and 6. So the only discordant case that we have in this quantification approach was a case where the immunohistochemical lab actually used the wrong staining, which I think is pretty cool. We are working farther in trying to actually analyze the concordance of the conventional immunohistochemistry versus the multiplex IF. This is work we are going to do. We haven't started yet with Predicts Bio, but I want to show you a little bit of the approach here. You can see how you can look at the conventional immunohistochemistry versus multiplex IF. In this particular case, they're both rendered digitally with colors, which are digital colors. We don't see the brown stain here. But because you have to do this in serial sections, unfortunately, because you're working with conventional lab-produced slides, which are by definition in a conventional immunohistochemistry, the bright field, the brown stains are all single slide. They're spatially not perfectly aligned by definition, and so you can see that the cells are not mapping perfectly, but you can do efforts to try to actually quantify them precisely. So giving you two examples, I think the first example was a case where there's pretty high concordance, not perfect mapping, but very close. And then you can see an example where there's a clear discordance between what you're seeing in the multiplex IF or NIF and in the brown stain in a particular case. And you can then map those spatially, and you can see where the areas of concordance and discordance are to understand exactly what is happening in a particular case. So that's work we haven't done yet, we plan to do in the future. But even from this superficial analysis, I think it's pretty convincing that actually we are in a position of demonstrating that the immunohistochemistry and the multiplex IF are highly aligned. So in conclusions, from a clinical perspective, we feel that we can address some of the problems which plague the diagnostic workflows of non-small cell lung cancer. We can reduce the number of slides that are needed. We do believe that it will make an impact from a clinical point of view if brought to the clinic. The work is pretty efficient. I think the time on the machine, the time on the platform, the time on staining is compatible with what you would do in a conventional lab. And things are quite efficient overall. I still do feel that there's a bridge we have to cross, though. If you think about people in the research labs and people in the clinical lab, they really have different views of pathology. I was mentioning before the folks in pathology really like the H&Es and have to interpret everything in the background of an H&E. The opposite is true for research. They really don't like to see those, and they actually don't know how to interpret them. They're really missing an opportunity, actually, because if you keep the pathology outside, you're going to get burned. At least that's the impression of a pathologist. So we need to bridge those, and I think that approach that I showed you before, where you merge the H&E in the context of the multiplex IF, is going to be super crucial. The other thing I want to mention is that workflows will need to be extremely robust and extremely efficient if you want to bring this to the clinic. pathology works. So, we were complaining about the fact that they have challenges because they're consuming too much tissue and they're not, and things could be done better, and they're missing the opportunity of multiplexing. But they, they produce slides every day. They make diagnosis every day on patients. Is a well-oiled machine and is a machine that works. And so whatever you do, you need to do it well. And workflows will have to be sorted out in a way that is, competitive with what exists now. You will not be able to approach this in a way that requires work on their side or is not incredibly efficient and aligned with what needs to be done. So I really hope that we'll be able to bridge this gap because I think that's what will be needed. I also have a comment about the utility of clinical work for research. I run a genomics clinical operation, so we do genomics in a clinical kind of setting. And I have to tell you that I feel the genomics field is way more robust, even from a research perspective, because of the input that comes from running every day in clinical labs. And if you talk with people who run TCGA and you look at how they interpret the results, you will scratch your head, unfortunately, quite often. And so I really think that bringing this to the clinic will benefit also the research arena. It's not going to be only important for the patients, but also for the investigators long term. Lastly, what else can be done on this platform? Well, I showed you the most simple kind of approach. That's what we were aiming for. But you can actually high-plex that more. I'm showing you here a 10-plex. We will not talk too much about this. But I also want to mention another thing that I think is important and is going to affect the field, which has to do with the fact that ADCs are going to hit us harder. We talked about a few before. There's more coming. I think there's 3 approval now by the FDA in the non-small cell lung cancer. It's true they are in a second-line setting, but if you want to be efficient, you want to run those up front for the patients. But there are many more on the horizon. So there's a broad landscape. The slide I'm showing you here is from Patricia LaRusso at ASCO 2025. You can see 450 ADCs have been at some point in the clinic. Not everything is successful. But many are still being developed currently, and many are now in clinical trials, and many will become available as therapeutic options for our patients. And I think I have a little table here. I think I'm highlighting in bold the ones which are approved. I think the list is going to get bigger. And so everything I told you before about the importance of the management of tissue is going to become more important in the future. I also feel that multiplex AF will have an incredible opportunity in the disease space. All the things that David Rim was mentioning before about the fact that brown stains are not good for quantifying anything will play out in this field as well. And so multiplex AF will become a major factor, I think, hopefully, if we want to have precise diagnostics for these patients in the near future. And lastly, I want to close this thanking all the people who actually did the work, Bernie Fox, and the lab of Bernie Fox did almost everything here. So Sean Jensen is here, and I think Quinn View is also here. Is now in Hamamatsu, but also did most of the practical work. I also want to mention Don Arya Kumar and Takuma Ito, which have been helping us on the Hamamatsu side. And I thank you all for your attention. I look forward to a few questions, maybe. It's a great question. I think there's going to be multiple types of deployment. So you may have a high-plex deployment where actually what you're looking for is a signature of some sort. So you could have a signature of responders versus non-responders. Ideally, we are in an immuno-oncology meeting, IO. And I think that's the window where you're going to see this very high multiplex kind of assays. I don't think pathologists or the clinicians would want to look at 40 stains. I think if you think about the workflows of the most complicated case, mostly HEMPAT, currently the range is typically 10, 15, but not 40 or 50. So I think there's going to be a limit from what can be done there that is interpretable by a human. Another thing is there's always conversations around potentially deconvoluting the high-plex and reducing the space of what is necessary from a diagnostic point of view. Predict Bio, which maybe in the room also has work in that kind of space. They try to take these very complex kind of data sets and then identify the few markers which are really crucial. So it will have to be seen. But personally, I feel there may be a signature space and there's going to be a diagnostic space here. The other thing I want to mention, the tumor microenvironment is super important. We worked on this many years ago, Immunoscore project and stuff like that. I think it's going to play out in ADCs, so it's very possible that the panel for ADCs may be the ADC antibodies, but also stains for the tumor microenvironment. But that needs to be proven in the future.
Carlo, just a question here. Great talk. Carlo, maybe you're the right person to ask this question from having worked with Dave Rim and also at Providence in the genomics capacity. What are the lessons we can learn in how genomics has been adopted clinically to bring about the adoption of multiplex? And maybe your thoughts around how we do that as a community.
Yeah. So David, has been working for 20 years on this, maybe more. I forgot. The time is flying. And he has made very strong statements already 20 years ago about how inaccurate fundamentally the conventional pathology workflows are. I do feel that we don't want to create enemies. We want to have friends in the pathology community, and that maybe some of the frankness on his side was not necessarily productive from a social point of view. So my personal recommendation would be to actually entice pathologists. I think there's a new generation of pathologists coming on board. They're looking forward to novel technologies. They realize they're going to be left behind between AI and genomics if they don't engage, and actually make their work more fun and more interesting rather than telling them, you're doing the wrong thing. Your current technology is not sufficient. It's not the appropriate one. Stuff like that. Yeah. Yeah, it's a great question. And I want to highlight also some limitations in the study. The study is retrospective. It's not a prospective study. So I do feel that this needs to be tested in a prospective study. There's many reasons for this. One of them is the fact that we chose relatively large-sized samples because we did wanted to preserve the tissue as much as possible for other uses. It was a research study, but if you build it prospectively, I think you will have to deal with very small biopsies, very small samples. I think that's where it is going to shine. But I think you need to show that actually in real life. And all the issues that you mentioned before about quality, I think will also become, will need to be assessed in that kind of setting. The other thing I want to mention also has to do with reagents. The reagents we have a batch of reagents, we ran them retrospectively. They all worked fantastically. Thank you, both of you. But a prospective study, you may have multiple batches of reagents, and you want to make sure that they perform in the same way across time, ideally across different platforms. So a necessary follow-up study of this is a prospective, ideally, clinical validation or clinical trial, informative kind of clinical trial, without intervention, but designed as a clinical trial kind of study. If you're planning to do that, and I hope we will get support. Yeah.
Well, thanks. We want to get to the next section, and we want to thank Carlo one more time, please. Great talk. Thank you, Dr. Bifulco. So the next section, we have Spatomics to give a, I won't introduce you.
just use a. Okay, cool. I don't need this one. Hello, everybody. My name is Xiaoshan with the Spatomics. I'm really happy to see everybody here, and also I really appreciate this opportunity from both the Hamamatsu and the BioCare for me to give everybody a brief introduction about what we do at Spatomics, the CFT, cleavable ceramide, and how this technology could help to achieve high-plex biomarker profiling in your lab. Okay, I think everybody is familiar with the TSA or ceramide signal amplification. It's a very efficient method to amplify the signal. However, with the conventional TSA assay, there's also a very obvious limitation. So when you are depositing your fluorophore, normally you are limited to only 6 to 8. Now, how do we break this hurdle? So we developed this cleavable ceramide or cleavable TSA technology. So from here you can see that diagram. Oh, sorry about that. Okay, all right, I didn't realize that. Okay, from here you can see that the diagrams are essentially very similar to traditional TSA assay. So where you use your HRP to activate the ceramide, and the ceramide will deposit on or around your target of interest. But here, what we did is we designed a cleavable linker in between the ceramide molecule and the fluorophore. So in this way, after your fluorophore to deposit on the tissue, you could use a mild cleavage reagent to wash away the fluorophore. Then the tissue is ready for the next round of staining. So in this way, you are able to break through the 6 to 8 plex hurdle and achieve a 10 plex, a 20 plex, or even higher. So in order to help to make sure we are able to make the fluorophore compatible with the different spectral systems, so we have designed 12 different cleavable fluorophores. So those 12 different cleavable fluorophores, they separated on the spectrum, and also they are drop-in compatible with your imaging system, either using a microscope or using a multispectral scanners, like the Hamamatsu multiplex. And then after you chose your fluorophores, and it comes to the workflow. The workflow is essentially very similar to what you're already using in your lab, the immunofluorescent, multiplex immunofluorescent workflow. So starting off from the FFE tissue, then the whole workflow can be automated on the auto stainers like the BioCare's OncoPro X, which we use in the lab, and also is compatible with Leica's BonRx. Then the whole workflow operates in the cyclic fashion. So you started from staining and imaging and a cleave cycle. So you could repeat this cycle multiple times. By doing the staining cycle, it's very similar to the conventional TSA. You lay down your antibody and deposit your fluorophore, and then before you are moving on to the next fluorophore, you have to strip off the antibody. If you're using the primary secondary antibody fashion, then depending on what kind of imaging system you're using, you could deposit multiple fluorophores on the same slide. Then go on to the imaging process. Then after the imaging is done, this is a special step. Then you could use our mild cleavage reagent, it's non-enzyme based, to remove all the fluorophore in one step. And after that, the tissue is ready for the next round of staining. So after the desired round of staining achieved, then you could have collected all the images and use either the commercial software or the open source software for image analysis. So with the repeating this multiple times, as I mentioned, that you are able to achieve 10 plex or 20 or even higher. Here's an example that we have imaged using the Hamamatsu's multiplex. This is the 6-plex the human tonsil and multispectral imaging. Then we chose the 6 different dyes and also constructed the on-mixing protocol. And with that on-mixing protocol, all the fluorophores are separated into a different channel, into the correct channel with a minimal background. And I guess that 6-plex is definitely not what you're looking for, so we also conducted a 10-plex mouse staining protocol. So this one, that we actually stain 3 rounds. I know not everybody are a fan of spectral mixing because this is still an algorithm. So in this case, we stain 2 to 4 markers per round, and it's separated into 3 rounds. So in the first round, we did 4 markers and did imaging and cleave off the fluorophore and go on to the next round. So in the third round, we collected 10 stainings, and also for the 3 round, we're using DAPI channel as a reference for image registration, and very similar to the other platforms. But the benefit of our platform is you do not need to use like a modified antibody. You can use your off-the-shelf antibody, and also this assay is compatible with a market-leading RNA assay like RNAscope, Molecular Instruments, HCR Pro. That you could use the RNA assay combined with your protein detection assay for a protein and RNA co-detection. So in this case, we only stain. In this case, we only stain 10 protein markers, and it's separated. Although it's separated into the multiple round, I think that also answers some of the questions that this assay maintains the tissue integrity pretty well. So even after multiple rounds with the staining and imaging, you are still able to register all the images really well. And in this case, we have, I think, the IBA1 and the TMM119. Where's that? Over here. So those are two markers that both target microglia, and they have a large overlap, co-localized presentation. So in this two, when you are overlaying them, you can see that the majority of them are actually overlapped. And here is actually one of our problems, but I want to use this one as a case that to show that we still have another advantage comparing to the conventional TSA. With the conventional TSA, if something happens, something's wrong, either one of the marker didn't work or you have an incomplete antibody stripping, and then you probably have to start everything all over. But with the cleavable TSA dye, this one, you can see that when we are first staining the GFAP marker, we noticed that there's some background noise coming from the new N channel, and possibly due to the incomplete antibody stripping. So in the later round, we did a signal cleavage, and also we redid the signal, antibody stripping. So we also, we assigned the GFAP to a new channel. And you can see that from the second round of imaging, we got a really clean background, no signal. So this means that the assay really gives you a lot of flexibility, and also it's kind of error tolerance. So it does not necessarily mean that you did one thing wrong, then you have to start all over again. You have the second chance to restain and either use the same antibody in the same channel, or even change your antibody clone and choose a new channel. All right. So we are in a multi-omics era. So protein and RNA co-detection is in high demand. I mentioned earlier that our assays are compatible with a leading RNA assay. Here, in this case, we use the molecular instrument HCR Pro and with a PPIB control probe, and along with the 3 T-cell markers that stand on TMA. And you can see that from here, we got the gold-colored PPIB signal, and along with 3 different T-cell markers are distinct to its cell. And from here, there's multiple organs showing a different TMA core. Like in the brain, you don't really see that much of immune markers, but also there's the PPIB expression is much lower compared to the tumor markers. So in a quick summary, I want to just bring everybody a new platform, a new assay called CFP cleavable TSA assay. So with this assay, you could use off-the-shelf antibodies, and also you could easily combine this assay with the on-market RNA assay, and also with the auto standard like BioCare's the OncoPro-X, and also the high throughput imagers like the Hamamatsu's multiplex, you can achieve high throughput and high plex biomarker profiling in your lab. All right, thank you, everybody. to take any question. Yeah, that's a great question. So I want to see that Spatomics is a startup company. We are only turning 2 years old. So in our lab, we currently don't have the capability to analyze the data. So we rely on the collaborators to do the data analysis. But you could use like a commercial software like Indica Labs, Halo, or Visufarm for data analysis. And also, if you are if you prefer, you can also use open source softwares. There's a lot of plugins or the pipelines on the QPath. You could use that. Oh, yes, sure. So like from Hamamatsu, the multiplex, they had a really good background subtraction algorithm. They can help you to get a much better result. And for sure, the software could help. But in our mind, that we'd prefer to present the raw data, because after the software process, it's all algorithm based. You may or may not get what you want.
So with our in-house, unmixing algorithm is really effective. So in this case here, like we have shown that we can do a 9-plex resolving very, very well, even at a 4-plex, right? And so you think like does not require unmixing, but the fact is the spectrum do overlap a bit, and so even with that level, right, we can apply this unmixing to resolve the signal even better. And so so in that, and then also with all these projects, we do an unstained slice, so we can see the level of autofluorescence. And that there, removing that out also help to resolve and clarify the image really, really well. And so, yes.
And if I want to get more in technical details from Hamamatsu, can I see how the instrument works? Because I'm aware what you have done in flow cytometry field.
Yes.
And that's why I came to it.
Yes. So this is our new field, right? And so in my background, right, I was effectively the beta user for this instrument. I work in the lab at the Providence Cancer Center, and so I got a chance to use this instrument. And so, from my perspective, right, initially, we know that with an imager, I need what? I need a very high quality image, and I need to be able to unmix. And so the fact that I can actually see and believe in a 9-plex resolving, that's pretty impressive. We know how difficult that is, right? And so yes, we would love to provide demo. And so you can. So that's the nice thing about this is this platform is agnostic, right? We're not fixed to any particular chemistry. And so we have filter, that we have fixed filter, but we have additional filter that can be added. And so depending on the chemistry that you're interested in, we can make sure that we can cache those images. And then using algorithm, we can So the point here is, for each of the dye, right, there's spectral chemistry, spectral. So when you import that in, we can apply that into our algorithm to specifically address your marker interest, your dye. And so we're not fixed to any chemistry in particular. And so that gives that flexibility, and we would love to demonstrate our capability in that capacity.
Sure. Yep. Sure. Yeah, so that's a great question. I actually got this question multiple times. People are really worried about the umbrella effect. So in our case, we found that maybe you will experience the umbrella effect in some extreme case, but in our study, we didn't do a very extensive study, but we have done some experiment. For example, we have compared two staining with the CD3E and a CD3D and a CD3E. So the two markers are very close together. And also on the serial section, we measured the CD3D and H3, which is one of the nuclear marker, one of the surface marker. And we found that the 3D reading, the fluorescent reading, is very comparable. And we are working on it to design a more sophisticated experiment to explain that. But in our case, or in our experiences, we haven't really experienced the extreme umbrella effect. And in one of the cases, a lot of people are also worried about running out of the tyrosine residue because the termite will bind to tyrosine residue. So in our co-founder, Dr. Jia Guo's lab at Arizona State University, we use the same marker, repeatedly stain the same antigen, and we stain it, strip it off, and stain it, strip it off, repeated for over 10 times, and the results are also comparable. Hope that answers your question.
All right, well, thank you, Spatomics and Xiaoshan, and once again, really appreciate